Today, we are not just talking about being tired.
Not at all.
We're sinking into one of the most fundamental yet frustratingly mysterious aspects of human existence: sleep disorders.
It really is.
We're talking about what happens when a bad night, turns into a chronic condition. It really starts to dictate every aspect of your life.
That's right. Sleep is not a luxury. I mean, it is a profound biological imperative. And when the systems that govern our wakefulness and our rest start to break down, well, the results are genuinely debilitating.
And it affects everything.
Everything, from your mood and metabolism to your cardiovascular health. So our mission today, it's really custom tailored for you, the curious listener who needs a clear, jargon-free roadmap.
And everything we're discussing is based entirely on the detailed sources we've been examining.
Correct. We are providing a deep dive into the major sleep-wake disorders, how they are diagnosed, what current clinical science prioritizes for treatment, and maybe most importantly, why the treatments often look so drastically different from one condition to the next.
I found it so interesting how the clinical lens has shifted over time. Historically, when people talked about sleep problems, they often circled around the more dramatic, almost narrative elements.
Oh, like nightmares and night terrors, right?
Exactly, or just mapping the basic architecture of sleep stages.
Right. But the source material makes it abundantly clear that the current clinical focus, where accurate diagnosis and effective treatment are yielding the biggest public health benefits, has significantly narrowed.
Narrowed how?
The field has really shifted its energy specifically toward three heavy hitters: insomnia disorder, obstructive sleep apnea, or OSA, and restless leg syndrome, RLS.
So these are the big three.
These are the disorders demanding the lion's share of research and clinical intervention right now.
And they really cover the spectrum, don't they? I mean, you have the psychological with insomnia, the mechanical with apnea, and then the neurochemical with RLS.
That's a perfect way to frame it.
But before we dive into the specifics of those, we have to establish the foundational diagnostic toolkit, because you can't treat the system until you know exactly where it's broken.
Absolutely. The backbone of diagnosis relies on a few critical tools that often work in tandem. First, there's the simple, but absolutely essential sleep log or sleep diary.
It sounds so low-tech.
It is, but it's indispensable. It requires the patient to meticulously track their habits: when they go to bed, when they attempt to sleep, when they wake up, and their perceived quality of sleep over a period of weeks.
So why is that simple diary so important, especially now with all the high-tech medicine we have?
Because it gives the physician vital insight into the actual rhythm and the behavioral context of the person's life.
Right, the real-world stuff.
Exactly. It checks for regularity, it identifies habits like going to bed too early or staying up too late, and it provides the subjective data needed to diagnose disorders like insomnia, which is defined largely by the patient's own experience.
But for the really complex biological and mechanical problems, you need something more.
For those, you need the big gun.
You do, and that is polysomnography, or PSG. For any listener who might be unfamiliar with the term, PSG is the gold standard.
It really is.
It's that comprehensive, all-night study conducted in a sleep lab, or I guess increasingly with advanced home monitoring systems.
PSG is a marvel. It tracks dozens of physiological parameters all at the same time. You've got brain waves, that's the EEG to identify sleep stages.
Muscle tone.
Right, the EMG to see if you're paralyzed during REM sleep, which you should be. It tracks eye movements, oxygen saturate, heart rate, and, critically, for disorders like apnea, the movements of the rib cage and abdomen along with the actual airflow.
So it's the complete picture.
It is the essential method for objectively analyzing sleep stages, timing, and diagnosing those complex mechanical and neurological conditions. If you're truly going deep on sleep disorders, you have to understand that the PSG is the ultimate map of the night.
Fantastic. With that diagnostic foundation established, let's jump right into the most common, the most frustrating, and I think the most relatable struggle of all: insomnia disorder. Insomnia, we all know that feeling. You're staring at the ceiling, watching the clock tick from 2 a.m. to 3 a.m., and that internal monologue is just running wild.
It's a horrible feeling.
And the definition here, based on our source material, it's a chronic struggle to fall asleep. So onset issues, or the inability to stay asleep, the maintenance issues consistently, and it leads to significant daytime distress.
And what's crucial to understand about insomnia disorder, especially when you compare it to an objective condition like apnea, is that its diagnosis is primarily, well, it's subjective.
It's based on what the patient says is happening.
Exactly. It's derived heavily from the patient's report of their difficulty.
So that distinction means the diagnostic process is rooted less in things like blood tests or objective mechanical readings and more in a really detailed clinical history.
Precisely. The diagnostic process is a combination of those sleep logs we mentioned, a deep dive into the medical and psychiatric history.
By psychiatric.
Because of the incredibly high rate of comorbidity with anxiety and depression.
Yeah.
The two are often linked. And then, of course, extensive patient interviews. Clinicians are trying to establish the pattern and the duration of the sleeplessness. It needs to happen at least 3 nights a week for 3 months for a diagnosis of chronic insomnia disorder.
Okay, this brings us immediately to a core point about treatment, which I think will be the aha moment for a lot of listeners who think insomnia treatment is just taking a pill.
Right.
According to the sources, the heart of successful long-term treatment is often cognitive therapy.
Absolutely. We need to dive into that cognitive component because it's where insomnia differs so fundamentally from a physical obstruction. Insomnia often becomes a self-fulfilling prophecy. It's a mental trap. Well, when a patient can't sleep, they start to worry about not sleeping. And that worry itself triggers physiological arousal. Your heart rate goes up, your mind races, which of course keeps you awake. It's a classic vicious cycle.
So cognitive behavioral therapy for insomnia, or CBT-I, it targets not just the behavior, but the thought process itself.
Exactly. Cognitive therapy targets the distorted cognitions about sleep, which often involve catastrophizing.
And the source material gave a perfect example of this.
It did. The thought, if I don't sleep in 40 minutes, I must have a serious disease or I will fail miserably tomorrow.
That's it. That dramatic spiraling, the moment the anxiety switches from being about the specific impact of the lack of sleep to being about the perceived failure of your own fundamental biology.
It is extremely common, that catastrophic thought, that 40 minutes of wakefulness is some kind of medical emergency that signifies impending doom. That is a hallmark of insomnia.
So how does the therapy fix that?
Cognitive therapy involves actively challenging and correcting that thought process. It means reframing the temporary inability to sleep as an inconvenience, not a sign of biological collapse. Clinicians teach techniques to detach from those spiraling thoughts. Addressing these distorted cognitions is just a non-negotiable foundational component of successful, lasting insomnia treatment.
So we start with the mind, tackling the anxiety. Now, what about the behavioral changes that support this new mental framework? These are often the hardest to stick to, but also the most potent.
That leads us right to the non-pharmacological first line of defense, or behavioral therapy. These are the foundation, and they're often deployed before you even think about resorting to medication. Everyone talks about sleep hygiene.
Right, the basics.
The basics. It's necessary, but it's often insufficient on its own.
Sleep hygiene is the dark room, cool temperature, no caffeine late, having a routine. But the two specific techniques mentioned in the sources that I think challenge patients the most are stimulus control and sleep restriction.
Let's focus on stimulus control first. It's radical in its simplicity, but it's incredibly difficult for chronic insomniacs to actually do.
And it's all about breaking an association.
It's all about breaking the conditioned association between the bed and wakefulness.
Meaning the bed should only be used for its intended purposes. Sleep and intimacy. Not for worrying, not for watching TV, and definitely not for doom scrolling.
Precisely. The rule is absolute. If you are awake in bed for more than, say, 15 or 20 minutes, you must get up and leave the bedroom.
You actually have to get out of bed.
You get up, you go to another room, do a quiet, non-stimulating activity like reading a physical book, not looking at a screen, and you only return to bed when you feel that unmistakable sensation of sleepiness.
Because if you just lie there frustrated,
The bed becomes a conditioned cue for anxiety. The patient must restrict the time spent in bed while consciously awake. The challenge for the listener here is, how do clinicians keep patients from cheating, from just staring at their phones in the living room?
well, the source material implies that adherence is managed through really rigorous logging and patient commitment, which is reinforced by the therapist. The therapy works because the therapist demands absolute compliance with that get out of bed rule, forcing the brain to relearn the association.
That's the critical point. Strict adherence is the therapy. Now let's talk about sleep restriction.
This is the one that sounds so cruel to an insomniac, cutting down on the time someone is allowed to even try to sleep.
I know it sounds completely counterintuitive. You're promoting sleep by intentionally depriving yourself of it.
So how does that work safely?
It is intentional deprivation, but it's highly structured and it's safe. It involves carefully managing the time spent in bed to closely match the actual time the patient is spending asleep. And what that does is it rapidly increases the drive for sleep, or what we call sleep pressure.
Can you give an example?
Sure. So if the patient spends 8 hours in bed but only actually sleeps for 5, the therapist might initially restrict their time in bed to just 5.5 hours, let's say from midnight to 5:30 a.m.
So you're dramatically increasing the likelihood that the person will use their allotted time for actual sleep.
Exactly. This increases their sleep drive and their sleep efficiency immediately. Then, as the time spent asleep improves and the patient becomes, say, 85 to 90% efficient, the time in bed is gradually and safely increased in 15-minute increments.
It sounds harsh, but it makes sense. You're condensing the sleep window to rebuild that natural, powerful biological drive that insomnia erodes.
You've got it.
And rounding out the behavioral approaches are the techniques we can use in the moment: relaxation and breathing exercises.
These are tools designed to downshift the autonomic nervous system. When your mind races, your body enters a fight or flight state. Your heart rate is elevated, you're on high alert. Relaxation techniques help regulate that physiological response, bringing down the heart rate and allowing the natural sleep mechanisms to kick in without being overpowered by anxiety.
Okay, that foundational CBT-I approach is critical. But if those behavioral and cognitive therapies don't work, or if the insomnia is particularly acute and short-term, that's when we move to the pharmacological treatments.
Right. And the source material notes, these are generally recommended for short-term use, mostly due to dependency risks and side effects.
So let's break down the drug categories because they work on entirely different mechanisms in the brain.
This is where we need to move beyond just simple listings and really understand the mechanics. Not all sleep aids are the same.
Let's start with the largest and most common group, the non-BZD benzodiazepine hypnotics. I think most people know these as the Z drugs.
The sources specifically name zolpidem, isoprolol, and zaleplon. They're chemically distinct from older benzodiazepines, but they operate similarly on the brain's inhibitory system.
How do they do that?
They enhance the effect of gamma-aminobutyric acid, or GABA, which is the major inhibitory neurotransmitter in the brain. You can think of GABA as the brake pedal for the nervous system. By enhancing GABA's effects, Z drugs put the brakes on brain activity, slowing things down to allow sleep onset and maintenance.
Now contrast that with the newer mechanistically distinct class, the orexin antagonists.
This is where the science gets really sophisticated. While Z drugs are trying to promote sleep by pushing the brake, by boosting GABA,
Orexin antagonists are trying to do what?
they're trying to block wakefulness by stepping off the gas pedal. Orexin, which is also known as hypocretin, is a neurotransmitter that promotes vigilance, alertness, and staying awake.
And the source names suvorexant as a primary example of this class.
Precisely. By antagonizing or blocking the orexin receptors, you dampen the brain's ability to sustain that intense wakefulness. You don't force sleep, you just remove the brain's ability to override sleep.
That's a subtle but really important mechanistic difference.
It is. And it offers a pathway to sleep with potentially different side effect profiles than the GABA enhancers.
Okay, shifting to the classics. Let's look at the original BZD hypnotics themselves. The source material distinguishes between these based on their duration of action, which dictates their application.
That's a key clinical distinction. Trazolem, for example, is a very short-acting BZD. This means it's metabolized and cleared quickly, making it primarily useful for issues related to sleep onset, helping the patient fall asleep right away.
And on the other end,
You have temazepam, which is longer acting. While it still helps with onset, its primary strength is in maintaining sleep throughout the night, reducing those frustrating middle-of-the-night awakenings. But it does carry a higher risk of next-day sedation.
and then we have the drugs tied specifically to the body's internal time clock, the melatonin agonists.
Right. Melatonin and the prescription option, rameltein, are fundamentally different from the others. They are primarily used when the insomnia is tied to a circadian rhythm issue. They work by signaling to the suprachiasmatic nucleus, which is the master clock of the brain, that it is time to wind down. They are not hypnotics intended to force immediate sedation. They are modulators intended to adjust the timing of the internal clock.
So they're perfect for things like jet lag.
Perfect for jet lag or for helping a shift worker establish a new rhythm.
Finally, the list includes antidepressants. Why would drugs like mirtazapine, trazodone, doxepin, or amitriptyline be used for sleeplessness? That feels like a crossover treatment.
And it speaks directly to the massive problem of comorbidity. The source notes these are particularly effective when depression or anxiety is comorbid with insomnia.
So you treat both at once.
You're trying to. While they are antidepressants, they have strong secondary effects that aid sleep.
But what's the mechanism, though? Are they also working on GABA?
Not primarily, no, not in this context. At the lower doses used for sleep, mirtazapine and trazodone are highly effective H1 histamine receptor antagonists.
Like an antihistamine you'd take for allergies.
Exactly. Blocking that H1 receptor is what causes that profound sedative side effect. Histamine is a key wakefulness promoter, so blocking it promotes sleepiness. Similarly, doxepin and amitriptyline are older tricyclic antidepressants, which are also powerful sedatives. When a patient's sleeplessness is rooted in or exacerbated by an underlying mood disorder, targeting both issues simultaneously is the most strategic and effective route.
That gives us a truly comprehensive view of insomnia. We moved from the foundational behavioral and cognitive tools, addressed the common pitfalls of adherence, and broke down 5 distinct pharmacological mechanisms. Okay, let's transition now.
Let's do it.
From an issue of the mind, the struggle to turn off, to an issue of mechanics and structure, the struggle to breathe.
Yes, we shift gears entirely here. Obstructive sleep apnea, or OSA, is fundamentally a structural problem where the airway physically collapses.
It's a plumbing problem.
It is. It is not about the brain deciding to stay awake. It's about the body being violently aroused hundreds of times a night because it is suffocating.
That is a harsh but very accurate way to frame the clinical picture. Let's look at the typical presentation and the cited risk factors.
The clinical presentation involves 4 classic signs. First, excessive daytime sleepiness, or EDS, that is just completely disproportionate to the hours spent in bed.
They sleep 8 hours but feel like they got 2.
Exactly. Second, very heavy, disruptive snoring. Third, and this is the most critical one, the partner or family member witnesses episodes of apnea, a complete cessation of breathing, or hypopnea, which is a significant shallowing of breath.
And the fourth.
Finally, morning headaches are very common, mostly due to poor oxygenation throughout the night.
And what puts a person at high risk for developing OSA?
The source material details several factors, with obesity being the single most important driver. Excess fat deposition around the neck and throat constricts the airway. Other risk factors include being male and middle-aged, having hypothyroidism, which can cause fluid retention and swelling of the soft tissues, and specific structural issues, like craniofacial abnormalities concerning the jaw or nasopharynx, which just leave less space for air to pass.
And because OSA is a mechanical problem, the diagnosis relies entirely on objective, measurable data. This is where that polysomnography, the PSG, becomes non-negotiable.
Absolutely.
Let's use the source's framework of the 3 parameters, airflow, rib cage movement, and abdomen movement, to visualize the 3 different types of apnea. This is how the PSG tells the story of what is going wrong.
This is the critical diagnostic deep dive.
Yeah.
You have to think of the PSG as tracking the effort, which is the rib cage and abdomen, versus the result, which is the airflow.
Let's start with the classic, obstructive apnea. What does the PSG trace look like during one of these events?
In obstructive apnea, the soft tissue, the tongue, or the palate collapses backward and physically blocks the passage, so the airflow stops.
But the body is still trying to breathe.
Desperately. The brain is sensing suffocation and is trying to breathe. So if you look at the PSG tracing, the respiratory effort continues. The rib cage movement and the abdomen movement are still going, and often they're increasing their force. The patient is struggling, pulling, trying to suck air past the physical blockage. It's the definition of a plumbing problem.
That paints a very clear picture of that struggle. Now, how does that differ from central apnea?
Central apnea is a problem with the respiratory control center in the brainstem. It's a problem with a central wiring signal.
So the brain just stops.
The brain simply stops telling the body to breathe. There's no effort. Therefore, not only does airflow stop, but both the ribcage movement and the abdomen movement also stop completely. It's a period of complete and frankly terrifying respiratory silence. This is often associated with neurological conditions or heart failure.
So central is a wiring failure and obstructive is a plumbing failure. What about the third type, which connects the two? Mixed apnea.
Mixed apnea is a combined event. It typically begins as a central apnea, so no airflow and no effort. But then, as the blood oxygen levels drop lower and the brain realizes the emergency, the respiratory signal kicks back in.
But there's still a problem.
Right. The patient is still lying on their back, relaxed, so when the effort resumes, they immediately transition into fighting against a closed airway. So it becomes an obstructive apnea. It begins with a failed signal, but ends with a physical blockage fight.
Understanding that triad is why the PSG is so powerful. It doesn't just say you stop breathing, it tells you why you stopped breathing.
Exactly.
Now let's define the key metric for severity, the apnea-hypopnea index, or AHI.
The AHI is the most important number generated by the PSG. It measures the average number of apnea events, that's the complete cessation of breathing, and hypopnea events, the shallow breathing that causes a drop in oxygen per hour of sleep. The higher the number, the more severe the condition and the greater the cumulative damage to the body.
And the source gives us precise criteria for severity, which is essential for treatment planning.
That's right. A diagnosis of OSA typically requires an AHI of 5 or more events per hour accompanied by symptoms, or 15 or more, regardless of symptoms. The severity tiers are: mild is 5 to 14 events per hour, moderate is 15 to 29 events per hour,
And severe.
and severe is greater than or equal to 30 events per hour.
Let's just pause on that severe category. 30 or more times an hour, your breathing is stopping or dangerously shallowing.
Yeah.
That's nearly once every 2 minutes, every single hour of the night. What are the long-term implications of that kind of chronic stress?
The clinical consequences are enormous. Each event causes a brief arousal and a drop in oxygen, putting enormous strain on the cardiovascular system. Untreated severe OSA is a major risk factor for hypertension, high blood pressure, atrial fibrillation, heart failure, and even stroke.
Not to mention the daytime effect.
Oh, absolutely. The sleep fragmentation also profoundly impairs daytime function, leading to increased accident risk. Treating severe OSA is a medical necessity, not just a quality of life improvement.
So once it's diagnosed, what are the primary treatment pathways? What is the undisputed, single most effective treatment?
The answer, which is strongly emphasized in all our sources, is positive airway pressure, PP therapy. This includes CPAP, which is continuous, BiPAP, bilevel, and APEEP, which is automatic.
And how does it work?
Essentially, a machine delivers a consistent stream of air pressure through a mask worn over the nose or mouth.
So how does that pressure mechanically solve the collapse?
It acts as a pneumatic splint. By keeping the airway slightly pressurized, it physically holds the soft tissues open and prevents the tongue and palate from collapsing backward when the muscles naturally relax during sleep. It addresses the mechanical problem directly and immediately.
But the challenge is getting people to use it.
The challenge, very often, lies in compliance, getting patients comfortable with wearing a mask all night, ensuring a proper fit, and managing any noise or dryness.
Beyond the machine, what are the recommended behavioral adjustments for OSA patients?
Weight loss is absolutely crucial for patients where obesity is a risk factor, as is positional therapy.
Sleeping on your side.
Clinicians encourage patients to sleep on their side rather than their back, often by placing cushions or devices to prevent them from rolling over. Sleeping supine on your back dramatically increases the chances of the tongue falling back and obstructing the airway.
Okay, and here is the critical warning that truly highlights why accurate diagnosis is life or death in sleep medicine. This is the huge difference between treating insomnia and treating apnea. We need to wave a giant red flag here.
This is non-negotiable. If a patient has OSA, they must strictly avoid respiratory depressants.
Which includes?
This includes alcohol, narcotic pain medications, and crucially, the same benzodiazepine (BZD) medications and related hypnotics we just discussed for insomnia.
Why? Why is a treatment for one so dangerous for the other?
Because BZDs and sedatives relax all muscles, including the pharyngeal muscles that help hold the airway open. So while they might help an insomniac's brain turn off, for an OSA patient, they make the airway collapse more easily and more severely, potentially leading to a life-threatening oxygen drop. The source material explicitly warns that BZDs must be avoided in OSA.
That is the perfect illustration of why the diagnostic clarity from a PSG is so invaluable. A medication that's a short-term tool for one sleep disorder is a severe complication for another.
It dictates the entire treatment trajectory. And finally, for the most severe cases, or for those who just cannot tolerate PDP therapy, the source does mention surgical options.
Such as tracheostomy and UPPP.
Correct. Tracheostomy, creating a permanent opening in the windpipe, is generally reserved as a last resort for extremely life-threatening cases. UPPP is more common. It involves surgically removing or altering tissue in the throat, soft palate, and uvula to try and create a wider, more stable airway. But its effectiveness varies, and PP really remains the gold standard.
We've covered the mind with insomnia and the mechanics with sleep apnea. Now let's shift to a disorder that is often described less as sleeplessness and more as an inescapable internal physical sensation, restless leg syndrome, or RLS.
RLS is a primary movement disorder, and its impact on sleep is just devastating because the urge to move is triggered precisely when the body is trying to rest.
What are the core clinical manifestations? What does it actually feel like for the listener?
It is defined by an overwhelming, often irresistible urge to move the legs. It's frequently described as tingling, aching, pulling, or a creepy, crawly sensation deep inside the muscles.
And it gets worse at certain times.
Critically, yes. These symptoms are aggravated by two things: night, evening, and periods of inactivity or rest. The moment the person sits down for dinner, gets on an airplane, or lies down in bed, the symptoms flare up dramatically.
And the only relief is moving.
The immediate, albeit temporary relief is movement, yes. Walking around, pacing, stretching, or vigorously rubbing the legs provides immediate temporary relief. This cycle rest-provoking symptoms, movement relieving them, is the hallmark that distinguishes RLS from simple leg cramps or general restlessness.
So let's talk about the why here, because RLS is a neurochemical puzzle. What is the core pathophysiology cited in our source material?
The source identifies a dual cause, and it's centered on the brain's movement regulation system. First, RLS is strongly linked to dopamine deficiency or dysfunction in specific brain regions. Dopamine is essential for smooth, controlled movement.
And the second part.
The second part, which is highly interconnected, is the link to iron metabolism disorders.
Why iron? That seems like an unlikely link to a brain movement disorder.
It's a fascinating metabolic connection. Iron isn't just for red blood cells. It is an absolutely essential cofactor for an enzyme called tyrosine hydroxylase.
And what does that enzyme do?
This enzyme is the rate-limiting step in the synthesis of dopamine. So if the brain's iron stores are low, it literally cannot synthesize enough dopamine to function properly. This creates a functional dopamine deficit, which leads to the RLS symptoms.
That makes the diagnostic process highly specific then. It's not just about symptoms.
Exactly. When diagnosing RLS, one of the crucial steps highlighted is measuring ferritin levels. Ferritin is the protein that stores iron in the body. If ferritin levels are low, clinicians aggressively treat the iron deficiency, and sometimes that alone can alleviate the RLS symptoms significantly without needing further medication.
Now for the treatment side. The source material highlights a significant shift in treatment preference that has occurred recently, representing updated clinical guidelines.
This is a really key insight. For decades, the primary first-line treatment focused on dopamine agonists, drugs like pranopexole and ropinirole. And they work brilliantly at first by mimicking dopamine in the brain and rapidly improving symptoms.
But the sources indicate that the gabapentinoids have now taken the top spot as the updated first-line treatment for chronic RLS. Why the change?
The change is based on a significant long-term complication associated with dopamine agonists called augmentation.
What exactly is augmentation, and how does it make the treatment fail?
Augmentation is a phenomenon where over months or years of using dopamine agonists, the RLS symptoms actually get worse.
Worse? How?
Not only do they become more intense, but they also start earlier in the day, sometimes appearing in the morning or early afternoon, and they can spread to other parts of the body, like the arms. The drug starts exacerbating the very problem it was meant to solve.
That sounds like a clinical nightmare for a patient who relied on that drug.
It is. And because of that risk of augmentation, clinicians have shifted preferences toward the gabapentinoids, specifically gabapentin and acarbol, pregabalin, and standard gabapentin.
And how do those work?
These drugs, which were originally developed for nerve pain and seizures, modify calcium channels and reduce nerve excitability. They effectively manage RLS symptoms, particularly the nocturnal component, while avoiding the long-term risk of augmentation that you see with the dopamine therapies.
So the core message for the listener is that while dopamine agonists are powerful, the long-term stability is higher with the gabapentinoids, making them the preferred starting point now.
Precisely. And of course, the general behavioral recommendations still apply. Ensuring optimal sleep hygiene and correcting any underlying iron deficits remain absolutely foundational.
We've covered the big three, insomnia, apnea, and RLS, with significant depth. But the source material requires us to delve into several other critical disorders that may be less common but are fundamentally disruptive. Let's start with the problem of too much sleepiness.
We begin with hypersomnolence disorder. This isn't just someone who enjoys a long lie-in or is generally lazy. The defining complaint here is excessive sleepiness, despite getting a minimum of 7 hours of sleep. The patient wakes up unrefreshed and experiences debilitating sleepiness, often requiring multiple long naps throughout the day that provide very little true refreshment.
How does that differ from the daytime sleepiness caused by fragmented sleep from, say, obstructive sleep apnea?
The key is that hypersomnolence disorder is often a primary neurological failure of the wakefulness system after you've ruled out insufficient sleep time or other medical causes like apnea.
So once the diagnosis is confirmed, the treatment focuses entirely on countering that pervasive sleep pressure.
Exactly, which means we immediately go to CNS stimulants. The treatment involves robust CNS stimulants, such as modafinil or various amphetamine derivatives. These promote wakefulness and vigilance, essentially overriding the neurological drive to sleep so the patient can function normally during the day.
Closely related, but with a far more dramatic presentation, is narcolepsy. This disorder has a very strict set of criteria that goes far beyond simple sleepiness.
It's a chronic, often lifelong condition. It's defined by an irresistible urge to sleep or sleep attacks. But the official diagnosis requires that pattern to occur for at least 3 months, 3 or more times per week.
But the true clinical signature of narcolepsy, the thing that sticks in people's minds, is a phenomenon called cataplexy.
It is.
Let's describe cataplexy in detail because it is terrifying and deeply distinguishes this disorder.
Cataplexy is the sudden, brief loss of voluntary muscle tone. It can range from mild weakness, like your jaw slackening, to complete collapse. The mechanism is a breakdown of the barrier between wakefulness and REM sleep. Normally, the paralysis that occurs during REM sleep is gated off during the day. In narcolepsy, that gate fails.
And the trigger is always emotional.
Always. Cataplexy is triggered by strong emotions, most commonly laughter, anger, surprise, or excitement. The person might suddenly fall to the ground, but, and this is the crucial distinction, they remain fully conscious throughout the entire episode.
They're temporarily paralyzed, but completely aware of everything happening around them.
Exactly. Which is terrifying.
That explains why the PSG and clinical markers for narcolepsy are so focused on the REM cycle and wakefulness promoters. What diagnostic clues are critical here?
Two critical biological markers are highlighted in the source. First, the measurement of low cerebrospinal fluid, CSF, hypocretin levels. Hypocretin, as we discussed with the orexin antagonists, is the master wakefulness promoter. Narcolepsy type 1 is often caused by the autoimmune destruction of the neurons that produce this vital chemical.
So low levels are the smoking gun.
They are. The wiring for staying awake has literally been destroyed. The second clue is found in the PSG, a shortened REM sleep latency.
Meaning they get to dream sleep faster.
Much faster. Healthy sleepers take 70 to 100 minutes to enter REM sleep. Narcolepsy patients can plunge into REM sleep within 10 or 15 minutes, even during a short daytime nap. Their sleep system is just bypassing the normal stages.
And treatment has to address those two distinct problems, the overwhelming daytime sleepiness and the sudden muscle weakness of cataplexy.
For the daytime sleepiness, the treatment is against CNS stimulants like methylphenidate or modafinil to force wakefulness. For the cataplexy, the approaches are different, often involving drugs like SSRIs or, very powerfully, sodium oxybate. These drugs help stabilize the REM sleep cycle and prevent that inappropriate intrusion of paralysis into wakefulness.
Moving on, let's look at the circadian rhythm sleep-wake disorders. This group feels so acutely relevant to the pressures of modern society, shift work, and the digital age.
It is. This is the conflict between our internal body clock, our natural preference, and the external demands of the clock on the wall. The core problem is a mismatch between the internal biological rhythm and the required environmental schedule. We all have a genetic chronotype, and sometimes our life demands simply run contrary to it.
And the source lists several common patterns of this mismatch.
Yes, we have the delayed sleep phase type, which is your classic night owl. They genuinely cannot fall asleep until 2 a.m. or later, and their natural wake-up time is 10 a.m. or noon. If they are forced to adhere to a 9 to 5 schedule, they are just chronically sleep-deprived.
And the opposite.
Then there is the advanced sleep phase type, the extreme early bird, who gets overwhelmingly sleepy at 7 p.m. and wakes up naturally at 3 a.m.
You also have the most disruptive types.
The irregular type, where sleep timing is random with no stable rhythm, often seen in neurological conditions. The non-24-hour type, usually seen in blind individuals who can't use light cues to reset their clock, causing their sleep phase to drift later and later each day. And of course, the highly relevant shift work type, which is endemic among medical staff, emergency responders, and factory workers, where their clock is constantly fighting the need to be awake overnight.
And finally, we get to the parasomnias. These are disorders where abnormal actions or behaviors occur while the person is asleep, often startling or even dangerous.
These are categorized based on which sleep stage they interrupt. Let's start with the non-REM arousal disorders. These occur during the deeper stages of non-dreaming sleep.
And this group includes classic childhood problems like sleepwalking and the far more intense sleep terrors.
During these NREM arousal events, the patient is often partially awake and partially asleep. In a sleep terror, they may scream and appear terrified, but the key clinical distinguishing factor is that the patient, upon fully waking, usually does not remember the episode.
So it's not a nightmare?
It's not a nightmare. They were not dreaming. They were in a state of confused arousal from duck sleep. Treatment is typically behavioral and aimed at safety, and often doesn't require medication.
In stark contrast to that deep, non-remembered sleep, we have REM sleep behavior disorder, RBD, which happens during the dreaming phase.
This is a classic example of a failure of a specific physiological mechanism. RBD occurs when the body fails to maintain muscle atonia. That's the natural, protective temporary paralysis that keeps us motionless during REM sleep.
So when that paralysis is lost,
The patient acts out their often vivid dreams, thrashing, shouting, punching, or fleeing.
the danger here is obvious, injuring themselves or their bed partner. How is RBD definitively diagnosed?
It is diagnosed via PSG. The test confirms the presence of intense muscle activity during the REM stage, which should be silent. It's a very strong indicator of neurodegeneration and is often a predictor of conditions like Parkinson's disease years or even decades later.
The treatment here is fascinating as it cycles us right back to our earlier drug discussion.
Yes, the primary treatment options are a low dose of clonazepam, which is a BZD, or sometimes high doses of melatonin. In this specific context, BZDs are used not as hypnotics to induce sleep, but to suppress the intense, dangerous muscle activity during REM sleep.
Yeah.
They stabilize the REM stage.
And again, it emphasizes that point. The same drug class BZD is used to stabilize muscle activity in RBD, used as a temporary hypnotic in insomnia and strictly avoided in sleep apnea. Understanding the specific broken mechanism is everything. This has been a truly expansive deep dive, moving from the subjective struggle of the mind to the objective failure of the body's machinery. We covered the three major pillars currently prioritized by clinical medicine: insomnia, sleep apnea, and restless leg syndrome, alongside the fascinating complexity of narcolepsy and the parasomnias.
And we established the critical diagnostic reliance on two tools: the sleep diary for understanding behavioral habits, and most crucially, the polysomnography, the PSG, for providing the objective data needed to pinpoint the precise location of the system failure.
We learned that insomnia is often a cognitive and behavioral issue, treated first with therapy like CBT-I, and then with a wide range of short-term pharmacological agents that either hit the brakes with GABA enhancers or step off the gas with orexin antagonists.
While sleep apnea is primarily a mechanical issue, the plumbing diagnosed by the AHI index and treated overwhelmingly effectively with P therapy. And crucially, we noted the strict avoidance of sedatives that could worsen that mechanical collapse.
And restless leg syndrome, the wiring issue, is a neurochemical or metabolic problem linked to dopamine deficiency and low iron, leading to that recent shift toward gabapentinoids as the first-line treatment to avoid the long-term risk of augmentation seen with dopamine agonists.
This is what I want you, the listener, to take away. Self-diagnosis based on daytime tiredness is insufficient and potentially dangerous. If you suspect a chronic sleep disorder, you must seek a professional diagnosis. The final provocative thought to mull over is how critical those high-fidelity diagnostic tests like PSG really are.
They're not just for identifying a problem.
No, they are for scientifically discerning which mechanism is broken, whether it's the mind struggling with distorted cognitions, the airway obstruction in the body's plumbing, or the precise neurological wiring involving dopamine or hypocretin levels.
Understanding whether your problem is cognitive, mechanical, or chemical dictates whether the solution is a behavioral habit, a machine, or a specific drug. The knowledge we've gained today is the first and most critical step toward observing your own sleep habits more closely and understanding which piece of the incredible, complex puzzle of human rest might need fixing.